Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. Today we'll be discussing on another very interesting topic. You will see good number of time in your everyday practice. We call that as peripheral arterial disease. Also, there was a broad term which was utilized, peripheral vascular disease. By and large, when you utter a word peripheral vascular disease, it is taken for granted arterial, but it also includes venous disorders and lymphatic disorders. So specific words should be utilized like peripheral arterial disease. Short form we call PAD. And peripheral vascular disease was labeled as PVD. But PVD also means peripheral vascular or venous. Better is peripheral arterial disease or peripheral venous disease. It is also called as a peripheral arterial occlusive disease. We'll be discussing under those common headings: definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, and treatment. So peripheral, when you use a broad term like peripheral vascular disease, it includes disorders that alters the natural flow of blood through the artery and veins of peripheral circulation. Lower extremity is more involved as compared to upper extremity, but you can get involvement of even upper extremities also. But when you use a specific term like peripheral arterial disease, means it is involvement of peripheral artery. And when you say venous disease, it is involvement of peripheral veins like varicose vein, deep vein thrombosis, and complications secondary due to those, or also be called as a peripheral venous insufficiency. So when by and large a broad term, when it is utilized peripheral vascular disease, it is commonly we should use a term like peripheral arterial disease or peripheral arterial occlusive disease, which is mainly occlusive disease of an artery involving the extremities. Lower limb more common than upper limb. So peripheral arterial disease is occlusive arterial disease. You can have aneurysmal formation, you can have inflammation or others. Inflammation like Burgers, Takayasu, etc. The most common cause of peripheral vascular disease, or we call peripheral arterial disease, is atherosclerosis. And second group we come across arthritis, like Takayasu we call aortoarthritis. Another we can include is Burgers. You can have aneurysm formation, you can have embolism, you can have acute or chronic. You can divide into functional and organic. Organic is, say example, atherosclerosis, and functional like spasm. Classical example, Raynaud's disease and Raynaud's phenomena. So we use different terms. We call peripheral arterial disease, acute or chronic, functional, organic. Etiology wise, separately we use the word peripheral venous disease, peripheral arterial disease, Burgers, Raynaud's disease, thromboembolism, vasculitis, spasm, compression, etc. There is one classification on the ground of clinical symptoms. It is called Rutherford classification and Fontaine classification. According to Fontaine, it is stage 1, stage 2A, 2B, 3 and 4. While in Rutherford it is 0, 1, 2, 3, 4 and 5, 6. So stage 1 is equivalent to 0, which is asymptomatic. 2A is equal to 1, which is mild claudication. Moderate to severe claudication 2B, and on Rutherford 2 and 3. Moderate is 2, severe is 3. Ischemic rest pain according to Fontaine is 3, and in Rutherford it is 4, while 4 in Fontaine is ulceration and gangrene, while in case of Rutherford it is classified into 5 and 6. 5 means minor tissue loss like ulceration, and major tissue loss like gangrene and amputation is 6. So whichever you use, better is separately. You can say asymptomatic, mild claudication, moderate, severe, ischemic rest pain, and minor tissue loss and major tissue loss. Or you can use a term ulceration and gangrene, whichever way you classify. 3 and 4, 3 and 4 of this, and 4, 5, 6 of Rutherford are also called critical limb ischemia. Critical limb ischemia. There is another classification, it is called as a SFA classification or task 2 classification. Type A, single occlusion, 5 centimeter in length. Type B, single occlusion, 5 centimeter but heavily calcified, and multiple occlusion, each of less than 5 centimeter or single more than or less than 15 centimeter. C is multiple occlusion of more than 15 centimeter. D is chronic total occlusion more than 20 centimeter. So this is A, this is B, this is C, and this is D. So this is called transatlantic intersociety consents, and it is superficial femoral artery occlusion. Superficial femoral artery occlusion. So that is depending upon how much is the occlusion of superficial femoral artery. It is classified into A, B, C, and D. This is on angiography or by using a Doppler, while this is clinical. This is clinical staging. Clinical staging is much better. Then when you go for investigation, you can utilize. Another way of classifying dilatation called aneurysm, stenosis or obstruction, atherosclerotic obstruction, thromboangiitis obliterans, or we call Burgess, acute embolism, polyarteritis, Takayasu, Raynaud syndrome. These are stenotic. Injury, AV fistula, and venous disease. This is which part of peripheral vascular system is involved and what type. Accordingly, you can classify. So this you can use, this you can call as anatomical and pathological. Etiology, it is large artery or small artery, but in general atherosclerosis, thrombosis, thromboembolism, TAO or Burgess disease, Raynaud's disease, thromboembolism, collagen disorders like SLE, periarteritis nodosa or rheumatoid arthritis, Takayasu, spasm like Raynaud's phenomena, compression syndromes, trauma, fibromuscular dysplasia, etc. So, and you can say lower limb involved, upper limb involvement. Now, depending upon the large size artery occlusion, most common is atherosclerosis and embolism. Small size artery occlusion, Burgess, Raynaud's, embolism, scleroderma, trauma, radiation, burns, pressure, necrosis, those groups. While medium size, with or without small vessel involvement, diabetes, recurrent trauma, multiple small emboli, collagen vascular disorders, polycythemia rubra vera, dysproteinemia, pseudoxanthoma elasticum, drug reaction, vasospasm, etc. Certain typical anatomical sites like cystic adventitial disease of popliteal artery entrapment, iliac endofibrosis, very common in cyclists. Certain compression syndromes like thoracic outlet syndrome, cervical rib, costoclavicular syndrome, scalenus tunnel syndrome, hyperabduction syndrome, quadrangular space syndrome, etc. These are all compressive syndrome where you can have a nerve compression or vascular compression or both together. That's why it is called neurovascular compression syndrome. Depending upon onset, acute and chronic, acute most common thrombotic and embolism, while chronic atherosclerosis and vasculitis, and also small vessel disease. There is one term which is very frequently utilized is acute limb ischemia, means acute in onset. Most common cause will be embolism, and that can be because of cardiac etiology like atrial flutter fibrillation or mural thrombus after MI or infective endocarditis thrombus from prosthetic valve or a diseased heart valve or arterial aneurysmal artery. It can be also due to thrombosis or trauma or arterial dissection. Rarely it can be paradoxical embolization from venous system, and if a person has got ASD or VSD, then from right ventricle it can enter into left ventricle whenever there is a reversal of the shunt. So then we call that as a paradoxical embolization. Acute limb ischemia, source of emboli is almost from heart in 90% of the people, while in case of a great vessels, that is we call vascular, will be only 9%, which can be from atherosclerosis, aortic aneurysm or popliteal artery aneurysms, and very rarely paradoxical, which will be coming from the venous side, that is deep vein thrombosis. And in a cardiac, or we call cardiovascular, that is arrhythmia, valvular heart disease, prosthetic valve, mural thrombus following infarct, or because of ventricular aneurysms, which can have a thrombus formation and you can have a dislodgement. Very, very rare from left atrial myxoma or right atrial myxoma, and that can also give rise to thromboembolism. Particularly in case of a valvular and prosthetic valve, it is infective endocarditis which can end up into embolism. Risk factors, there are modifiable risk factors like diabetes, smoking, hypertension, hyperlipidemia, physical inactivity, obesity, alcohol, and non-modifiable risk factors like genetic, race, gender. This is the most common risk factor. You can see smoking is the most common. Then comes your what we call as diabetes, hypertension, sedentary lifestyles, etc. As far as TOO, thromboangiitis obliterans or Buerger's disease is concerned, age is between 20 to 40. It is extremely common in male. It involves small and medium size artery. Usually large size artery are not involved. The artery which is involved is not thickened. There is a diffuse inflammatory reaction involving all the layer, resulting into obstruction. Smoking, hypercoagulated stage, autonomic hyperactivity, low socioeconomic group are the risk factors. Raynaud's disease is common in female. Female to male ratio is high. Upper limb are more involved than lower limb. There will be digital ischemia and Raynaud's phenomena on exposure to extreme cold, stress, etc. or after doing an exercise. Peripheral pulse are normal, and there will be recurrent episode whenever there is exposure to cold. Very characteristic of Raynaud's disease, or we also call as primary Raynaud's phenomena. As far as pathophysiology of peripheral arterial disease is concerned, because of involvement of the peripheral arteries, it will lead to obstruction, and secondary to obstruction, lack of blood supply, which will lead to ischemia. Second mechanism of ischemia, this is because of obstruction because of say atherosclerosis, thrombosis or embolism. But second mechanism is vasoconstriction or we call vasospasm, which is quite common in say Raynaud's disease or also common in vasospastic disorders. Some of the Raynaud's phenomena, and you can have a partial occlusion or complete occlusion of the artery. As far as a partial occlusion, atherosclerosis is the most common cause, and complete occlusion is very commonly because of embolism, and that embolism can come from many. Most common cause is cardioembolism, and second common is from blood vessels like blood clots. We already mentioned the etiology. Once there is a partial occlusion, it will lead to ischemia, that is claudication. When occlusion becomes more, person will start getting race pain, and when there is a complete occlusion, person will have a critical limb ischemia leading to ulceration and then gangrene, and it will be a dry gangrene. So usually person will come to you with the symptoms cold extremities, pallor, rubor. This will be classical scene in case of what we call as a Raynaud's phenomena. Particularly initially the person will have a cyanosis followed by a pallor followed by cyanosis followed by redness. Person will complain of pain, skin changes, changes in the nail, and even person can have gangrene and auto amputations. Also, there will be atherosclerotic changes, thrombus formation, embolization secondary due to atherosclerosis. There will be increased chance of coagulability. Person can complain of hypertension secondary due to atherosclerotic changes. And at the site of ischemia, you can have changes in the skin, nail bed, terminal part, and you can have gangrene formation, you can have infection, ulceration, etc. And secondary to atherosclerotic, you can end up with unstable angina, STEMI, non-STEMI, together we call as acute coronary syndrome, ischemic stroke, TIA. As far as peripheral artery is concerned, we get critical leg ischemia, and involvement of the coronary artery can end up into acute MI and can cause cardiovascular death. This is secondary due to atherosclerosis. But as far as peripheral arterial disease is concerned, atherosclerotic will give rise to damage to intima, thrombus formation, ischemic changes like claudication, race pain, and then person can end up with ischemic damage like ulceration and gangrene. Now, as the occlusion occurs gradually, you can have a collateral developments, and once there is a collateral development, even after a complete occlusion, person can have a little amount of blood supply by collaterals. The gangrene part may not take place. We have already mentioned regarding a pathophysiology before. This is a little difference between chronic limb ischemia and acute limb ischemia. In acute limb ischemia, it is mainly because of embolism or thrombosis. It is sudden occlusion, so usually there is no time for collateral development. May occur in few hours up to 15 days. There is mottling of the skin, sensory motor loss, and gangrene formation. While in a chronic limb ischemia, it is very common because of atherosclerosis or say disease like TAO. It is slowly progressive occlusion. Symptom will take more than few days or maybe even more than 15 days. Symptoms will occur from few days to 15 days duration. There is a imbalance of oxygen supply and demand. So it produces anaerobic metabolism leading to intermittent claudication followed by race pain and then ischemic ulcer and gangrene. While here it will occur very fast. Usually progress of intermittent claudication can occur say it starts in 5% of the people. Peripheral vascular outcome will be worsening of claudication in 16%. Lower extremity might require a bypass surgery almost in 7%, and 4% will require a major amputation. While in case of a cardiovascular mortality and morbidity, non-fatal strokes can occur up to 20%, while 5 years mortality is almost 30%, and cardiovascular cause of death will be almost in 75%. So indirectly, atherosclerosis can end up into cardiovascular death, quite common. Critical limb ischemia, we already mentioned the commonest is atherosclerosis and TAO. We have already mentioned all those. Because of occlusion, there will be anaerobic metabolism, lactic acid production, and P substance production, which will give rise to pain. We call as intermittent claudication. The risk factor we have already discussed. All those modifiable and non-modifiable risk factor we have already shown you. Indirectly, those are all the risk factors for atherosclerosis. So you've got atherosclerotic peripheral arterial involvement, mainly more commonly is lower limb than upper limb. During exercise or during increased oxygen demand. Now there is an anaerobic metabolism because demand is more, supply is less. Lactic acid production and P production, P substance, and person will start complaining of pain because of lactic acid and other metabolites. When person takes rest, this lactic acid and metabolites are washed out, pain disappears, and again person can start walking. But what is rest pain? Because of severe atherosclerosis, even during rest, oxygen demand cannot be fulfilled. So even during rest also person gets anaerobic metabolism, lactic acid production, rest pain. Now this lactic acid and metabolites, that is substance P, cannot be removed, cannot be washed out. So person continues with a rest pain. And when there is a complete occlusion, no blood supply, no oxygen supply, death of a tissue, necrosis, we come across what we call as a dry gangrene, which is identified by line of demarcation, shrinkage of the tissue, and black color discoloration, and loss of sensation, etc. in the part which is being affected. And at the line of demarcation, there will be hypersensitivity. Person with peripheral artery disease can present as an asymptomatic when the occlusion is less than 50%, and if there are good collaterals. Pain is the most common symptom. We call intermittent claudication. Person can have edema, paresthesia. Skin temperature will become low. It will be usually cold. Skin color changes can take place, and there will be changes in the appearance in the form of loss of hair, etc. And particularly when person does an exercise, the pain will appear, we call as intermittent claudications. As far as the venous involvement is concerned, if you get an edema, it is called venous edema. And if there is a lymphatic occlusion, it will give rise to lymphedema. Paresthesia is the most common symptom, like heaviness, tingling, numbness, burning sensation. And as it advances, person can have even loss of sensation. Skin temperature can become cold. There will be abnormal color. Slowly, the changes in the color will appear with pressure. Changes in the color will appear with physical activity. And also, person can have color change in different position. Like while you are doing a burger's test, the skin color changes will change. If you look at the artery peripheral pulse will be low volume and sometimes it can disappear. At the site of obstruction, you will have a bruit and you will have different area of involvement of the artery. You might have a pulsatile mass or a non-pulsatile mass. Skin changes can appear like ulceration and gangrene. Because of a chronic nutritional supply is also reduced, the limb growth may be affected. The affected limb may be little thinner as compared to the opposite limb. So person usually will be asymptomatic in very early stage, and later on he can present as an intermittent claudication and can end up with what we call as a critical limb ischemia. A part of critical limb ischemia is wrist pain, ulceration and gangrene. Or person can directly go into acute limb ischemia, that is because of embolism or because of rupture or because of dissection. By and large, usually it is intermittent claudication going into critical limb ischemia, which will consist of wrist pain. Then person starts developing ischemic damage like ulceration and late stage gangrene. But occasionally person from asymptomatic can directly go into acute limb ischemia. Not very common, but when embolism takes place, very common. Or because of rupture of aneurysm or because of dissection, etc. You can see here 50%, more than 50% of the people develop atypical symptom, while typical symptoms are seen in only 33%. What are typical symptoms? That is intermittent claudication. Classical, that person gets pain on exertion, and as soon as the person takes rest, within 10 minutes the pain will be relieved. While atypical symptoms are that leg pains are there, may be involved in the area other than the calf, may not stop the patient from walking, may not resolve with rest. These are called atypical symptom, and it is quite common in almost more than 50% of people. So do not forget this atypical symptom. Peripheral arterial disease can present as an acute ischemia, chronic ischemia or acute on chronic. Three common way of presentation. We have already told you, depending upon the different stages, stage 1 asymptomatic, stage 2 intermittent claudication, stage 3 rest pain or maybe atypical pain or maybe even a nocturnal pain, and last we call as these two, 3 and 4 are called critical limb ischemia. The last stage we call as a necrosis, ulcer formation, necrosis followed by gangrene, or we call dry gangrene. I have already shown you this slide, so I am skipping over this particular. Intermittent claudication will come while walking. It is not present during rest, does not appear with few steps. The pain will appear after walking some distance, and that distance is called claudication distance. That claudication distance is reproducible walking the same distance. Say person says that while walking from one particular spot to a second spot, next time also while walking for the same amount of distance, person will get that pain. So claudication distance decreases as the limb ischemia increases, and particularly while climbing up and down. In a neurogenic claudication, opposite will take place. That is, claudication distance will increase while climbing up and will decrease while climbing down. While in case of a peripheral arterial disease, claudication distance decreases as person starts climbing up because he requires more exertion, and while climbing down the exertion is less. While it will happen exact opposite in a neurogenic claudication. This claudication pain is relieved by rest within few minutes, does not disappear after stopping walking, and can be relieved even by standing, but it will be after some period of time. The pain history, person can have different types of presentation like pain, aches, tiredness, tightness, soreness, weakness, numbness, etc. By and large, this will be presenting in the form of a chronic presentation. We already described. Other symptoms can be burning pain or aching pain, cold clammy extremities, increased occurrence of infection at the site of ulcer, non-healing ulcer. Very, very rarely person may be asymptomatic. Very, very absolutely rare. If a person gets critical stenosis, now person will start presenting as a rest pain, ischemic ulceration, and can end up into gangrene. The most common vessels which are being involved is iliac, we call bifurcation, iliacs, most common iliacs, and femoral artery, most commonly involved. And when you get involvement of aorta and iliac, you will have a pain at the buttocks and hip claudications. In almost 30% of the people, person can have impotence, and then it is called as a Larich's syndrome. If femoral are involved, thigh claudication will be there. As it comes lower to superficial femoral artery, the person will have almost in 60% of people upper two-thirds of the calf claudications. And when it comes to popliteal, it will be lower one-third of the calf area. And when it is a posterior tibial artery involvement, foot claudications. As occlusion advances further, there will be rest pain. Person will get pain while resting. It will be more common in forefoot and toes, distal part of the limbs. Pain will be relieved by hanging leg down or sleeping in a chair. It will be worsened by elevating the limb, because the blood flow will decrease when you elevate the limb. That's the reason why when the person starts climbing, there is decrease in claudication distance. Very typical. It is not responding to usual analgesic. You might have to give a narcotic analgesics. Person may have also, instead of pain, can complain of dysesthesia, that is hyperesthesia or paresthesia. It is aggravated by elevating the limb and relieved by limb dependency if limb is lower down. It is increased in arterial pressure from gravity. Non-functioning veno-arterial reflex will take place, and that will help in relieving that pain. In a critical limb ischemia, you will have a color changes, ulceration, and later on gangrene formation. The distalmost part may show you gangrene. So rest pain, pedal necrosis, and then later on person can develop gangrene. There will be tissue loss leading to ischemic ulcer, non-healing ulcers, even after minor trauma or surgical incisions. So ulcer formation and dry gangrene will be common findings. So this will be gangrenous part, what can happen. Wet gangrene will occur only if there is an infection. By and large, the clinical presentation, you can see that almost in 50% it is asymptomatic. Atypical pain is almost in 33%. Classical symptoms are only in 15%. And 1 to 2% can directly present as a critical limb ischemia in the form of a rest pain and then ending into ulceration and gangrene. Acute limb ischemia can have 5P, that is pain, absent pulse, pallor, paresthesia, paralysis, cold clammy extremities, also called as a poikilothermia, and purplish motile. These are 6P. So these are the common presentation. This is very commonly secondary to embolism or from thrombosis. There is a fixed area of mottling and cyanosis in this particular type of presentation, what we call as acute limb ischemia. There is a little difference between embolism and thrombosis. Embolism is complete occlusion without collaterals, while in thrombosis it is usually incomplete with little amount of collaterals. Embolism will occur in few seconds to minutes, while thrombosis will take hours to days. Lower limb involvement and upper limb involvement in embolism is almost 3:1, while in thrombosis it is 10:1. By and large, classical acute limb ischemia will occur in case of embolism rather than thrombosis. So in thrombosis, there will be previous history of claudication, then ending into an acute limb ischemia. Bruit will be present in case of thrombosis because there is a partial occlusion, while pulse will be totally absent. So embolism very easy to diagnose clinically, while thrombosis can be diagnosed mainly by Doppler or by angiography. Treatment in case of embolism will be embolectomy or using anticoagulants. While in thrombosis, you will have to use thrombolysis, and later on, depending upon the amount of involvement, you can go for bypass grafting. This we have already mentioned different stages in acute limb ischemia, stage 1, stage 2, 2AB, then 3, etc. So this is a involvement in acute limb ischemia and difference between arterial and Doppler arterial and Doppler venous is mentioned. What are the sensory findings, what are the muscle findings, etc. are mentioned, particularly of acute limb ischemia. You can go in detail at your leisure time. This is critical limb, we already mentioned intermittent claudication, and that will end up into critical limb ischemia. We have discussed before already. At your leisure time, you can go through. I am mentioning some of the other differences. As far as the arterial pulse is concerned, arterial pulse will be low volume to even very difficult to palpate. Bruit will be very common. Thrill will be palpable over the occluded artery, which is usually partial. Person will have a typical symptoms like rest pain in a critical limb ischemia, and there will be changes in the skin like loss of hair, brittle nails, muscle atrophy. Skin changes will take place. The temperature will be cold and skin color will also change. You will have a formation of ulcer. You can have a Berger's sign positive, and we call Berger angle will be there. You might have dependent rubor, ulcer formation, and then later on dry gangrene. You can have a impotency in a male, particularly in aortic bifurcation and iliac involvement, that is called Leriche syndrome. Berger's angle will be demonstrable. By and large, it is close to 30 degree. And when the limb is lower, you can have dependent rubor formation. We have already mentioned in previous, according to the Rutherford classification, you can go for chronic limb ischemia. That will be typical. There is a Boyd's classification. I am skipping over all these different classification. You can see this is a critical limb ischemia, gangrene formation already. So this is critical limb ischemia. So clinical finding, this will be inspection, palpation, auscultation, and then these are different tests. On inspection, thin skin, hair loss, brittle nail, color changes, ulcer, muscle wasting. On palpation, temperature will be cold. Whichever limb is more involved, there will be more coldness than opposite limb. It may be unilateral or maybe bilateral. Pulse, you will find difficulty and there will be difference in the pulse palpation. Capillary refilling time will be prolonged. Sensation will be lost. You can have a bruit or a thrill. Systolic blood pressure at the ankle and brachial artery will be different. So ankle brachial index will be markedly affected. It will be less than 0.5. And Berger test elevation up to 45 degree you will see a pallor, and when you put the leg in a dependent position at 90 degree, the red flush foot will appear and pallor will be less than 20, and you can have, when it is at less than 20 degree, it indicates severe peripheral arterial disease. Now this is one very useful slide. So peripheral vascular disease, these are all the etiology showing you almost everything whatever we have uttered at present. So these are all what we call is the risk factors: diabetes, smoking, obesity, infections, injury to the vessel, sedentary lifestyle, hypertension, autoimmune disease, nutshell, nutritional deficiency, high blood hyperlipidemia, embolism, etc., inflammations. What is peripheral arterial disease? That is described here. We have already mentioned all those and different stages we have mentioned. This will be the different symptoms right from asymptomatic to stage 4 we call critical limb ischemia. And as far as laboratory investigation is concerned, angiography, laboratory testing to find out the risk factors, Doppler to find out the severity of occlusion, and angiography will also help to find out that pulse palpation at ankle and blood pressure, that is ABI index. This is in nutshell entire picture. And some of the laboratory parameter which is very helpful is lipid profile, homocysteine, C-reactive protein, blood glucose, ferritin level, and lipoprotein level, that is lipids, lipoprotein levels. So this is in nutshell, in short. When you start taking a history, history should be taken properly. Do you get any symptoms while walking? How long you can walk? What happens when you get the pain? How far you can walk? When you stop? What stops you when you are walking? All those different ways of asking those questions. Do you had ulcer? How it healed, etc. So detailed history should be taken, which will help you to differentiate acute ischemia from chronic ischemia. Physical examination should be done. We have done all these parts before. And this is diagnostic algorithm we already mentioned before. Any person in whom the history is suggestive of a ischemia, or we call peripheral arterial disease, you will have to differentiate into 3 groups: acute or chronic, or person had already chronic and now he has got an acute symptoms. So acute on chronic, and if it is acute on chronic, arteriography should be done and he should go for thrombolysis. In case of a chronic, you can use Doppler, ultrasounds, and then followed by arteriography, and then you can have treatment for atherosclerosis and preventive measures you can take. And in case of an acute, if the artery is not palpable, then you can go for that palpable contralaterals, collaterals, contralaterals, popliteal aneurysms. If you are suspecting this, you should go for arteriography. If clinically you are not suspecting and you are suspecting cardioembolism, then go for finding out the cause of cardioembolism like ECG, echo, etc. And then you can go for arterial embolectomy, and you can go for anticoagulants, etc. We know very well Burger disease is more common in male. Atherosclerosis is also at the old age and more common in male as compared to female. Raynaud's disease is common in female. Diabetic is more common in middle-aged groups. Burger disease very frequently will involve, Burgers and atherosclerosis will involve lower limb, while Raynaud's will involve upper limb. If there is bilateral or unilateral involvement is more common in Burgers and Raynaud's. Atherosclerosis can be unilateral or can be bilateral. Gangrene is usually unilateral. Diabetic gangrene is again unilateral, more common as compared to bilaterals. We have already told you that gangrene due to atherosclerosis, Burger's disease, Raynaud's disease will occur acutely or maybe gradually, while embolic is always sudden with severe pain. And usually in case of atherosclerosis, Burger's disease, it will be dry gangrene, while in case of diabetes, invariably it is a wet gangrene. We already mentioned the site of pain. If it is in the gluteal region and upper part of thigh, it is more common in aortoiliac involvement. If it is in the mid thigh, it is a femoral artery. If it is in the upper part of the calf region, it is mainly femoral, and in lower part popliteal. This we have already mentioned. And if it is in the foot part, it is tibial, posterior tibial or plantar arteries. Depending upon the claudication distance, etc., you can classify. That is called Boyd's classification. By application of warmness will increase the symptoms of arterial occlusion, while in Raynaud's phenomena, intermittent attacks of pale and cyanosis and pink will occur. And on dipping into a warm water, person will get relief. Usually there will be local cyanosis, then you will have a pallor followed by cyanosis followed by recovery, and in the end stage you will have ulcer formation and gangrene. So different stages, that is pallor followed by cyanosis followed by rubor. This is pallor, cyanosis will be very common followed by rubor. Paresthesia will be very common in intermittent claudication. In some of the condition, you can have a supercilious phlebitis, particularly in case of aortoarthritis. You can have a physical examination and local examination, including inspection, palpation, auscultation, and then general examination. This is, you can see, ulcer, typical non-healing ulcers, very commonly in the plantar surface of the foot. This already we have mentioned before. I've shown you this slide before. So you look for the skin color changes, signs of ischemia, Burger test, capillary refilling time, venous refilling time, etc. So look for the changes in the color like pallor, cyanosis. Look for signs of ischemia like skin color changes, temperature, color changes of the skin, brittleness of the nail, etc. Trophic changes of skin and nail. This is Burger's postural test. When you are elevating the limb, at what level the pallor appears. That so if it is less than 20, it is severe peripheral arterial disease. Look for capillary refilling time. If capillary refilling time is prolonged, it is sign suggestive of a limb ischemia. Venous refilling time will tell you the venous involvement. Look at the different changes like changes in the skin color, dry or wet, line of demarcation. Particularly this will help you to identify arterial and venous gangrene, and also infected like in case of diabetes mellitus. In palpation you can look for skin temperature, capillary refilling time, venous refilling time, cross leg test, cold or warm water test, elevation of arm, Allen test, Brenham signs, costovascular compression maneuvers, hyperabduction maneuver, gangrene area, crepitus, you can palpate blood vessels, etc. So you can look for all this capillary refilling time, venous refilling time, and this venous refilling time is also called as a Harvey's sign. So in a poor limb ischemia, there will be increased in arteriovenous fistula and venous refilling will be affected. Cross leg test you can try, and this is to detect the popliteal pulsation, and that is also called as a Fuchs test. When there is a severe arterial spasm, usually it is very commonly because of Raynaud's disease or Raynaud's phenomena, where ice cold water will precipitate and warm water will give you a relief. Elevated arm test is very important in case of a thoracic outlet syndrome. Allen test is also helpful to find out the compressive pathophysiology. This is typical Allen test. There is one Allen test which is being done to identify the ulnar or radial artery involvement. And there is one test, sorry, it is not Allen test, it is Edson test. This is Brenham test, which is performed when arteriovenous fistula is suspected. That is called Brenham test. This is that costoventriculavicular compressive test, or we also call as Edson test. This is that Edson test. Then you can look for dry gangrene or wet gangrene. You can look for crepitus, and you can look for gangrenous area above the gangrene, whether it is normal or abnormal. You can palpate all the peripheral blood vessels, that is all dorsalis pedis, posterior tibial, anterior tibial, popliteal, femoral, radial, ulnar, brachial, subclavian, common carotid, and superficial temporal. All these arteries should be palpated. And depending upon palpable, etc., you mention the scale. If it is totally absent, 0. If it is low volume, 1. It is normal, we call 2. It is little large volume, 3. And if it is bounding, 4. Usually in a peripheral arterial disease, it will be less than 2. So it will be either 1 or 0. This is typical Edson test, which is very commonly to find out the cervical rib or scalenus anticus syndrome, producing compression of blood vessels. On auscultation, you can hear a systolic bruit. On aneurysm, you can hear a systolic murmur. And in case of arteriovenous fistula, you can get a continuous machinery murmur. You can look for general examination finding for atherosclerosis, embolic phenomena findings. A person who is having diabetes mellitus, which is accompanied by atherosclerosis, try to look out for different findings. ABI index can be done. This will be you try to differentiate thrombosis from embolism by clinical examinations. This is arterial versus venous. This I'll little highlight that. In arterial there will be intermittent claudication, pain at rest, pain with elevation, dusky red, slight redness will appear when you lower the limb. The limb will be cold, edema will be usually absent, or if at all if it is present, it is very mild edema. There will be skin changes in the form of thin, shiny, atrophic skin, loss of hair, nail will be brittle, ulcer may be seen, and you can have a gangrene formation. While if it is a venous insufficiency, usually no pain when it is dependent area, pulse are normal, normal color, cyanosis will appear when the limb is down. There will be brown pigmentation in the lower part of the limb. You can have a small petechial hemorrhages. Temperature will be usually normal. Edema will be a prominent feature. You will have a dermatitis and thickened skin. You will have a non-healing ulcer at the ankle, mainly medially. Mainly medial. This is very typical of venous. So same thing, given a difference here between arterial and venous. You can go through at leisure time. The description is between skin, pain, ulcer, pulse, edema, etc. This is again a difference between a vascular and neurological. In vascular, the onset is predictable, while in neurogenic, it is variable. Vascular will come only on walking. This will not be classical in case of walking. Vascular will be relieved by standing or stop walking, while you will have a variable response on in neurological. Pulse will be usually low volume and absent, low volume or absent, while in neurogenic it will be very typical variable. And we have mentioned one thing, in vascular while climbing a staircase it will increase the symptom signs and symptom signs will decrease little bit while coming down the staircase, while this will be just opposite in a neurogenic etiology. There is something called as a claudication and pseudo-claudication. Now, classical claudication, person will complain of cramping, tightness, aching, fatigue, etc. While in this, the clinical complaint is same. But in addition to that, tingling numbness will be a typical or burning sensation. Claudication will be more common in buttock, hip, upper part of thigh, calf and foot. Here also it is almost distributed like claudication. Very typical. Claudication will come on exercise, while this may be variable. Distance is constant, while in pseudoclaudication it will be variable. Person will get relief by standing, and usually there will be no claudication on standing, while here good number of time it is on long standing. Relief will be there very frequently by standing, while this person will sit and change the position. Then person will get a relief. If person is sitting or changes the position, then there will be relief. Person will get a relief of claudication within 5 to 10 minutes, while this will take longer time, almost 30 minutes. Little difference between that, pseudoclaudication and claudications. This is a difference between intermittent, venous and neurogenic. I am skipping over this. At your leisure time you can go through. This is a difference in lower extremity ulcer, arterial, venous and diabetic ulcer. If you are interested, at your leisure time you can go through difference between arterial ulcer, venous ulcer and diabetic foot we call. As far as investigation is concerned, history, physical examination is the most important to find out and differentiate between peripheral arterial disease, venous disease and other. ABI index is very useful to find out the involvement of the lower limb. Doppler is another very important to find out the involvement area and severity. And final is angiography, which is combination of MRI with angiography or CT combining with angiography or digital angiography. So depending upon which is required, it can give you the severity of involvement. History and physical examination is the most important part. So don't forget that. Already we have told you that in acute limb ischemia, always look for the site of embolus and thrombosis, and in that very important investigation is cardiovascular examination like ECG, echo, very important. Duplex will be another important to find out the arterial involvement, and person might have to go for what we call as CT angio, MRI angio, because they will have to undergo urgent treatment, and this may be required in an early stage to find out the severity of involvement at the site of involvement, and then you can go for anticoagulant, thrombolysis, or you can go for angioplasty, etc. As far as a chronic limb ischemia is concerned, ABI index, arterial duplex, then you can go for digital subtraction angiography, CT angio or MRI angio, etc. may be helpful. So in a chronic limb ischemia, ABI index is very, very helpful. And severe the ABI index. So if any ABI index become less than 5, it is usually suggestive of a critical limb ischemia. And in a case of a gangrene, it will be less than 0.15 also. Duplex scan is the most important, which gives you a lot of idea regarding arterial studies. Digital subtraction angiography is another very, very important, and it will give you in detail regarding the arterial blood flow, collaterals, etc. CT MRI angio is another investigation which can help you to find out the severity. Blood test is mainly to find out the risk factors. There are some non-invasive like duplex ultrasound may be of help. By and large, the non-invasive CT angio, MRI angio and digital subtraction angiography are the gold standard, and that should be done in a critical limb ischemia, and they are also helpful in a case of an acute limb ischemia. So these are non-invasive investigation and these are invasive. Non-invasive are better than invasive because this will have a complications in invasive, and in non-invasive usually certain complications are avoided. So you can go for a non-invasive test more as compared to invasive test. So non-invasive tests are preferred, and of that duplex ultrasound is most useful, and it can be done even at the bedsides. And then you can go for another test which is very, very important is ABI index, etc. So ABI index is very, very helpful. These are the common indications in which you should do it. I'm not going into detail now. At your leisure time you can go through. This is an entire procedure, how you do ABI procedure. This is after doing an ABI procedure, you try to find out the ratio. And we have already mentioned that if a ratio is less than 5, it is suggestive of a critical limb ischemia. This is typical. This is very, very typical exercise test you should go for. So less than 5 indicates severe or critical limb. You can go for even ABI with segmental pressure studies, which will give you which portion of the artery is being involved. You can also go for pulse volume recording. That will also give you an idea regarding the involvement. I have told you that duplex scan or duplex Doppler gives you a wonderful idea. So arterial duplex ultrasound gives you a wonderful idea along with Doppler. CT angio is one of the study which can be useful. 3D constructive, then digital subtraction will be another. MRI angio is another study. You will have to differentiate different disease like atherosclerosis, TAO, vasculitis, and there is a big list. You can go through that. Because peripheral arterial disease will include all these conditions. So you'll have to differentiate because in each condition, the treatment is different. So try to differentiate vascular from neuropathic, neurospinal, musculoskeletal disorders, etc. So you will have to undergo different studies because these are vascular etiology, these are neurospinal, these are neuropathic, these are musculoskeletal. So try to find out those causes. As far as the treatment part is concerned, you have to achieve the 4 main goals. You have to prevent the limb loss. You have to relieve the symptoms. You have to increase the circulatory capacity, and you should reduce the cardiovascular risk because it can recur. So you can give medical therapy and endovascular therapy or surgical intervention. As far as medical therapy is concerned, risk factor modifications. Modifiable risk factor can be modified. Non-modifiable, you cannot. exercise therapy can be done, and you can use drugs for control of all those risk factors. As far as endovascular therapy is concerned, transluminal, stent, angioplasty, laser, cryo, atherectomy, or thrombolic, what we call as a thrombolysis, or you can combine thrombolysis with combination of this mechanical, etc. And when that does not work, you might have to go for bypass grafting, or it may end up with amputation. In some condition, and atherectomy may be of great help. So treatment includes risk factor modification, that is smoking cessation, BP reduction, lipid lowering, claudication exercise should be done. So regular calculated exercise should be done. Medical treatment like antiplatelet therapy may be single or dual antiplatelet therapy. You can use silostazole. Foot care can be taken. You improve the functional quality, and you want to preserve the limb, and you want to prevent the progression of atherosclerosis, and try to identify and treat the systemic atherosclerosis. So this is a simple slide which shows you lifestyle modification. So these are all lifestyle modification, what you should include in nutritional, what you should avoid. There are some herbal preparation which can also help you out. There are something which you should avoid other than nutritional supplements is quit smoking, maintain your body weight, get adequate sleep, maintain your personal hygiene, particularly of lower limb, obtain proper nutrition by these nutritional supplements, avoid junk foods, fast foods, healthy foods should be taken, get pedometer, physical exercise, avoid injury, and as far as medical treatment is concerned, maintain blood pressure, manage blood sugar, balance hormones, remove obstruction, minimize the clotting risk, reduce inflammation, and take care of the extremities. There are some other treatment which are being tried like massage, hyperbaric oxygen, and compressive boots. It will depend upon the amount of involvement, etc. And this is what is done every day. This is done 3 to 5 times a week. Then further you can increase, and then you can cut down. So depending upon, this is called exercise pyramid for healthy lifestyle. So usually graded exercise, aspirin, lipid lowering, silostazole, foot care, and aggressive control of comorbid conditions like diabetes, hypertension, etc. So these are all modifiable risk factors which you have to control. Exercise, medical management by dual or single antiplatelet therapy, silostazole, foot care, etc. Lipid lowering drugs, rigid control of hypertension, diabetes, and lipids should be done. And then you can go for endovascular management like angioplasty or stenting. If surgical treatment required like bypass or atherectomy, which can be open also, or at the end, if this doesn't work, amputations. So this is angioplasty, balloon angioplasty followed by stenting. This is bypass grafting. These are different grafts, autogenous grafts, synthetic grafts. You can use, these are synthetic grafts. You can go for saphenous vein grafts, etc. And these are the algorithm how you approach. You can go through your at leisure time. This is management of peripheral arterial disease, asymptomatic group, what you do, lifestyle, etc. What you go for at your leisure time, you can go through. This is another one, non-invasive imaging, and then depending upon that, you can go for bypass grafting, stenting, as well as you can do at the level of the original blood vessel which is being occluded, what you can do. This is treatment of acute limb injury where you will require to revascularize as early as possible to prevent a loss of tissue like balloon angioplasty, embolectomy, or even go for intraarterial thrombolysis, etc. You can go for all those things, thrombolysis, you can go for. So these are catheter directed thrombolysis, short form it is called CDT. So you can go for all those different types of uh, mechanical and chemical revascularization. You can have a reperfusion syndromes sometimes at the local level, compartment syndrome, systemic effects, cardiopulmonary complications. You can have renal tubular necrosis, myoglobin can be precipitated. All this complication can happen secondary to reperfusion syndrome. I am not going into detail regarding all this different. In a case of traumatic occlusion, you can go for surgical intervention. And if there is a complication, you will have to treat those complications. After doing a reperfusion therapy, you can have a myoglobinuria leading to acute renal failure. So you might have to take care of that. We have already mentioned before, quite common. This is acute limb ischemia together, etiology, clinical features, treatment part, and this is complication after treatment. So go through at your leisure time. It is a combined what is being given. This is algorithm which you can follow in case of acute limb ischemia, starting from history, peripheral artery embolization, what are the clinical findings, what investigation you should go for, and what are the treatment, etc. How you approach. This is for clinic we call critical limb ischemia, where intermittent claudication, critical limb ischemia, and then person goes into gangrene. What you do when there is an intermittent claudication and when there is a critical limb ischemia, what you can go, we have already mentioned before. Very frequently person will have to go for percutaneous transluminal angioplasty. That is most commonly nowadays being done, means with balloon followed by stenting most commonly, and it is very good in case of a critical limb ischemia. You can go for a bypass and you have got lot of different types of stents which are available. Different types of stents which are, these are long stents and these are stent with the two bifurcations. So those are different types of, and this is a mind map, that is etiopathogenesis, symptoms, signs and treatment and investigations, which you can follow in chronic limb ischemia. Chronic limb ischemia and critical. As far as complication is concerned, in arterial, dry gangrene, cerebrovascular complications, coronary artery complications, and invariably secondary due to these two, person can even have a death. So outcome, major cause of mortality is because of cardiovascular and cerebrovascular complications. So at the end of the lecture, I thank you all. I know that your time is valuable and I appreciate you for spending some of the time with me. I hope this lecture will be helpful. Good number of time you will come across in your everyday practice a person with a peripheral arterial disease. If you pick them early, if you identify the etiology and at what stage he comes, you will be able to pick